ready.
Yeah.
Yes, madam. Hello, everyone. A very warm evening to all the delegates, faculty members, delegates, dignitaries, and friends joining us today. To begin today's program on an auspicious note, I request Mr. Arun to kindly render the Kasoga prayer song. Thank you, Mr. Arun, for the beautiful prayer song. It is my privilege to warmly welcome our dynamic Kasoga Endoscopy Committee Chairperson, Dr. Prabhati Desai, Madam.
Yeah. Thank you, Dr. Shisha. And I'm extremely happy that Dr. Shisha has taken as a secretary responsibility for this one year tenure, whichever is now remaining.
Thank you, Madam, with all your support.
Yeah. And I welcome everyone for this I think these 2 years, last 1 year's first webinar. And I welcome our dynamic past president, Durgadas sir, and the present president, Dr. Rajeshi Palladi madam, Dr. Shobha Gudi. I am always happy that Shubha Gaudi Madam has almost encouraged for my all webinars, and she has seen that she will be there for these webinars. And I welcome our speakers, today's speakers, Dr. Parikshit Tankar, Dr. Sonal Madam, and of course, I am giving one talk. And our chairpersons, Dr. Rajesh Bhatta sir, Dr. Sneha, अपने Dev Madam, Sushma Dev, and my friend who is very much active in endoscopy in rural area, Dr. Krishnavardhan, for this today's webinar. With this, I would like to hand over to for further proceedings with Dr. Shisha.
Thank you, Prabha Desai, Madam. To formally welcome the gathering, I now request our respected Kasoga Secretary, Dr. Shobha Gudi, Madam, to deliver the welcome address. Madam, may I request you to kindly address the audience?
Yes. Thank you so much. And I would be rather just welcoming, not the welcome address will be given by the President, Dr. Rajeshi Palladi, and other comments by the past president and the incoming president. Am I audible?
Yes, madam.
Yes, madam.
Yeah. So I'm delighted that endoscopy committee work is progressing so smoothly. And I have a lot of trust and faith in Prabha because I have seen her skill of communication, and I'm actually grateful to Dr. Durgadas for honing that skill. And because he gave her such a free hand, and she came out in full bloom last year. And of course, this year also, there is a very daunting task for you because the president has outlined so many new initiatives. Yes. So I'm very happy that you have chosen ectopic pregnancy as the topic because it is still such an enigma and you have to keep thinking ectopic to pick it up. So it's very good that you have addressed the window period between the diagnosis and the laparoscopic intervention. I congratulate you for that. Though being a surgeon, you have brought in this clinical phase where we can perform medical management and improve the non-surgical outcomes. Thank you for giving me this time. Over to you, Srisha. Over to you.
Thank you, Dr. Shobha Gudi, Madam, for your warm and inspiring welcome. It is now my honor to invite our esteemed President, Dr. Kasoga President, Dr. Rajashri Palladi Madam for the presidential address. Madam, kindly address the gathering.
Good evening, everybody. And I'm extremely delighted that the webinars by the committee chairpersons are being conducted so robustly. Hearty congratulations to the Endoscopy Committee for taking up this webinar at such short notice. This year, Kasoga, we have planned and streamlined the programs in such a way that weekly we have a webinar by one of the committees. And I'm glad that Prabha has taken up this initiative very well. And Sirisha, welcome to the brigade. And I'm glad that young talent
Thank
is
you,
getting
madam.
promoted and being given the opportunities to exhibit their performance. I heartily welcome and thank the speakers for today's evening, Dr. Sonal Panchal. We are moving across the borders to spread our Kasoga logo and Kasoga banner, and also the academic exchange, which helps us a lot in gaining more skills and having more exchange of knowledge, so that this will become a platform wherein anybody would log in and learn more. And having chosen ectopic pregnancy, because this is one scenario wherein we want to retain the fertility of the woman and also give her the best of the advices, so that in the future, already she has lost 50%. So we would like to retain the other part of it, is what the challenge which all of us face, be it medical management and surgical management. So a very good initiative and talk, because many a times we find that there could be pregnancy of unknown origin, wherein even just to know where the location is, we may have doing a diagnostic procedure. And I would also like to thank Dr. Parikshit Tank. In spite of the busy schedule, they have accepted our invitation and agreed to be here. Of course, our chairpersons are very own Dr. Rajesh Bhakta, who is a good friend, Dr. Sushma, another dear friend, and Dr. Krishna Vardhan for taking up this initiative to join us. And uh, best wishes for all the future endeavors. And Prabha, we have a lot of activities promised, and we are looking forward that you'll fulfill the workshops and the live workshops and etc., because the calendar is quite full. And we would like that the endoscopy committee correlates with the office of the Kasoga to know where the slot is, because that full is the plate now for the next 2 months. But nevertheless, the physical CMEs and hands-on skill transfer is what is very much required and needed, because many of the juniors are looking out for having the hands-on experience of the endoscopy work. And I think this is becoming one of the most favorite subjects even by the newcomers, because it's it's a challenging deliverance of these skills. So with this, I would not stand between the speakers, because we have many interesting talks lined up. Looking forward for more physical on-site CMEs also, and skill transfer programs. Hearty congratulations and all the best.
Yeah,
Thank you, Rajeshri Palladi Madam, for your encouraging and visionary words. We shall now begin our scientific session. The first topic, early diagnosis and triage of ectopic pregnancy. Our chairperson for this is Dr. Sushma Dev Madam.
Dr. Shisha, introduce Dr. Sushma Dev. Arun?
Dr. Sushma Dev Madam, Professor and Unit Head, Mysore Medical College and Research Institute, Director and Chief Consultant, Aishwarya Hospital, Mysore. Madam is Organizing Secretary, Foxy South Zone Conference with UVA 2024. Chairperson Quiz Committee, Kasoga 2020-2022. Secretary Mox Mysore 2020-2022. President SMFM Mysore Chapter 2022-25. Dr. MG Hiremat Yuva Oration at Kasoga 2021. Madam is Organizing Committee Member, ISSHP World Congress 2023 Bangalore. Madam received Teacher Excellence Award IAGE 2024. Conducted quiz at Kasoga Conference during the years 2021-2022. She is the member of Endometriosis Committee, Foxy 2020-2021, member of MTP Committee, Foxy 2021-24, member of Practical Obstetrics Committee, Foxy 2025-2028, Master Trainer, Obstetrics HDU ICU, MOHFW, Government of Karnataka, CAC Master Trainer, EC member, Medical Research Unit, MMCRI. Over to you, madam. I request Sushma Dev Madam to kindly introduce the speaker, Dr. Sonal Panchal Madam, and take over the proceedings of the session. Over to you, Madam.
Thank you very much for the kind introduction. Indeed, it's a great honor and pleasure to be part of today's scientific session. And of course, congratulations to Dr. Prabha Desai for coming up with a wonderful program. And I'm very happy. It's always been a pleasure to work on the guidance of our dear President, Madam. And today's talk by Dr. Sonal Panchal, who is a pioneer in the field of gynecological ultrasound. It was a pleasure for me, and it's on that I was part of her fellowship programs in the ultrasound. And Madam really needs no introductions because the whole Foxy family knows Dr. Sonal Panchal. To tell in brief, she's done PhD in ultrasound in gynecology, and she's the consultant at Nagore Institute of Fertility and IVF, Ahmedabad, and Director, Center of Excellence, Donald Inter-University School, and National Advisory for the Board Member for the International Journal of Fertility. She's been a reviewer for Journal of Human Reproductive Sciences as well, and she's delivered more than 1,000 lectures and contributed and authored many chapters. And indeed, it's a great honor to have you and listen to you, Madam. We welcome on behalf of Kasoga. Over to Madam.
Yeah. Hello. Arun? Hello, Mr.
Yes,
Arun?
madam. Yes,
Can
madam.
you just, connect the madam screen share madam's talk.
One nimsham.
If you have a difficulty, you tell me, I will screen share from here.
Yeah, please share it.
You want me to share?
Yes, madam.
Wait. Wait. Screens share, but what? Yeah, wait. My screen is visible? Yeah.
Yes, madam.
Especially to Dr. Desai for this opportunity. I'm going to talk today on early diagnosis and triage of ectopic pregnancy, chiefly based on the ultrasound. Talking about ectopic, the first and the foremost dictum is you must think ectopic to diagnose an ectopic pregnancy. Unless the ectopic is thought about, it is impossible to diagnose it early. Ectopic pregnancy is suspected when the patient presents with period of amenorrhea and positive beta-HG, vaginal spotting and irregular vaginal bleeding, abdominal pain, or vasomotor shock and fainting, and it may be a combination of all or any of these symptoms and presentations. On clinical examination, there may be hypertension, tachycardia, abdominal distension, tenderness is very, very typical. There may be a shifting dullness, and this is especially seen in cases where the ectopic is ruptured. There may, if you do a pulmonary speculum examination, you may find blood-stained discharge, and on the PV examination, there would be tender pornosis and tender cervical movement. Biochemically, ectopic is suspected when you do a beta-HCG level and it is low than the expected according to the duration of amenorrhea. It is in these cases that many times, in spite of a missed period, there would be a negative urine pregnancy test. There is a slow rise in the beta-HCG. So the primary level is low and the rise in the beta-HCG level is also low. The normal rise, as we know, is 1.7 times daily, or at least 53% in 48 hours. When it is less than that, that is when ectopic pregnancy is suspected. Moreover, when you're doing vaginal scan, you expect to see the gestational sac intrauterine when the beta HCG reaches 1500 milli-international units, and this would confirm a normal intrauterine pregnancy. But in spite of that cutoff of 1500 milli-international units, if you're not seeing an intrauterine gestational sac, that's when you would suspect a possibility of an ectopic pregnancy. But it is very important to remember here that though usually ectopics show low level and the slow rise, but still 5 to 8% of ectopics will still have a live embryo, and they were therefore present with normal beta HCG levels. It is also important to remember and understand that if you wait for beta HCG to reach that discriminatory level of 1500 milli-international units, it is often possible that because it is an ectopic, because it grows slowly, because the beta HCG rises slowly, and therefore it would take very long before this level is reached, and therefore if at all there was an ectopic pregnancy, your diagnosis may be made very, very late. And it is, we all know that the early diagnosis of ectopic is very important. It is very essential because that would reduce a lot of fatal outcomes as much as 75%. But it also is very important to prevent the morbidity because of the ectopic pregnancy as well as its associated complications. So you must be very alert and aware to get beta HCG levels tested and diagnose ectopic on time. But on the other hand, it is also very important to understand that the beta HCG levels, though they are highly sensitive, they are very specific when it comes to the diagnosis of pregnancy, because you may see, you may get positive beta HCG levels, or higher beta HCG levels even in the patients who have gynecological tumors, some of them, and you may also get them positive in tubovarian abscesses, and some tranquilizers also lead to rise in the beta HCG levels. So it is both false positive and false negative. Moreover, when you do a beta HCG level, it only tells you there is a pregnancy. It's very difficult to confidently diagnose just based on the beta HCGs, as this would be an intrauterine or an extrauterine pregnancy. That means, yes, beta HCG is a test which is done primarily, but you need a transvaginal ultrasound. And this is a modality of choice for the diagnosis of ectopic pregnancy, or to exclude the possibility of an ectopic pregnancy and confirm the diagnosis of an intrauterine pregnancy. The transvaginal scan truly has a high sensitivity, 96%, and specificity, 88%, positive predictive value of 89%, and negative predictive value of 95% for the diagnosis of ectopic pregnancies. Using a protocol of combination of clinical examination and history, serum beta HCG assay, and TVS, it is possible to diagnose ectopic pregnancy with 100% sensitivity and 99% specificity. And when we talk about ectopic pregnancy, though they may be found in the ovary, broad ligament, uterine cornu, maybe in the cervix, in the myometrium, in the scars, but 95% of the ectopic pregnancies, they occur in the fallopian tube. That means when we're using transvaginal ultrasound as a diagnostic test for ectopic pregnancy, it is this ultrasound which also confirms the intrauterine pregnancy and thus completely can exclude the possibility of ectopic pregnancy. And what are the signs of intrauterine implantation for the ectopic pregnancy? And these are very important to remember and keep in mind, especially when you are doing scans early, or you have your beta HCG levels and you are trying to locate the intrauterine pregnancy. And these signs of intrauterine implantation, which are even before the gestational sac appears, is echogenicity of the endometrium, which is very high. I mean, the endometrium is very hyperechoic. The decidual echogenicity is very different from that of a normal secretory endometrium, as we all know. There would be asymmetrical thickening of the endometrium, as you can see in the first image. The anterior lip is much thicker than the posterior lip. And this is because we know that the implantation occurs into one of the endometrial lips, and it is not in the center of the cavity. Moreover, there's a localized area of increased vascularity. It feels like all the vessels are converging towards one single point, and this is called a color comet sign, again, a sign of an early pregnancy. So even before the gestational sac appears, you can if the beta acids are high and you're not finding any intrauterine sac, if you're finding any of those findings which have been just discussed, tells you, yes, this is an early intrauterine pregnancy. Though the sac is not seen, the implantation is most likely to be intrauterine. Coming to the signs of ectopic pregnancy, and since we have discussed the uterine signs, let us start with the uterine signs for the ectopic pregnancy also. And these are very important. These are indirect signs, but these are very, very important. First and foremost, there is going to be an empty endometrial cavity, which we all know, but more importantly, there is a symmetry of both the lips of the endometrium, and this is what tells you the implantation is not intrauterine. It may be no pregnancy or it may be an ectopic pregnancy, but it is not an intrauterine pregnancy. It may or may not show increased endometrial thickness due to decellulite reaction, and sometimes it also shows a coagulum in the retrouterine space. So those apart from that, you would also see sometimes a pseudo-gestational sac, which is a fluid-filled structure seen in the endometrium. This often can be confused with the true gestational sac, but it is the differences are that the pseudo-gestational sac is always central, whereas a true gestational sac is always eccentric. There is no double decidual sign. The hyperechoic rim that you're seeing surrounding the true gestational sac is never seen in the pseudo-gestational sac. If you switch on a Doppler, you are not going to see any vascularity surrounding the pseudo-gestational sac, and moreover, it may change its shape with the uterine contractions, which is never the case in the true gestational sac. So these are four very important differentiating points between the true gestational sac and the pseudo-gestational sac. Let me remind you, it is the pseudo-gestational sac which is a structure or a uterine sign of an ectopic pregnancy. It can be seen in about 10 to 20% of the patients with an ectopic pregnancy. Coming to the direct signs and the adnexal masses. Now, for that matter, I would say that in a patient with a missed period or and a high beta HCG beyond 10 mil international units, if this patient shows any adnexal mass, so let's put it this way: there's a patient who has a missed period, who has high beta HCG, who has who has symmetrical endometrial cavity and shows an adnexal mass, even if it is an isoechoic adnexal mass, like a soft tissue blob, extrauterine, extraovarian, unless proved otherwise, this is thought to be an ectopic pregnancy. Additionally, to confirm the diagnosis, you can put on a Doppler and confirm that it has a ring of vascularity of fire, a ring of fire or a ring of vascularity, and moreover, it is also tender on probe pressure. The presence of the yolk-sac embryo and the heart activity are not very common, or they come very late in the ectopic pregnancies, seen in only about 15 to 28%, and therefore these are not to be used as the standard features on ultrasound for the diagnosis of the ectopic pregnancy. The sac without embryo may be seen in about 46 to 71% of the ectopic pregnancies. That means empty sac is a more common finding. So you would see an isoechoic mass rounded up away from the outside the uterus, outside the ovary, tender on pressure. Sometimes it may show central hyperechoic area, which is because of the early decidual reaction, and after the development of the gestational sac, this decidual reaction is pushed to the periphery of the anechoic area. So you're seeing a typical appearance, anechoic area, hyperechoic rim, and an isoechoic thick margin, which tells you it is an ectopic pregnancy. Sometimes it may also show mildly irregular shape because these are usually not healthy pregnancies. You may often see free fluid in the pouch of Douglas. You may see free fluid surrounding the ovary and the adnexa, sometimes with thickened tubes. And moreover, you see a corpus luteum on the same side as an adnexal mass, which tells you this is most likely an ectopic pregnancy. Apart from that, if you're diagnosing this pregnancy early, very early during its development, that is when free fluid, thickened tubes, you may also see a localized ring of vascularity in the thickened part of the tube. And your 3D may also show a gestational sac inside. There cannot be a more confirmatory demonstration of the pathology than this. You're also seeing here mild fluid in the tube. So this is a very early pregnancy, and this images can be achieved by 3D ultrasound or 4D ultrasound with volume contrast imaging, which enhances the contrast. So just to repeat, you will first have a blob sign, that means a soft tissue adnexal mass, and along with that, sometimes you may see a gestational sac inside, but many times it would be just a soft tissue blob. You may see the free fluid, you may see the femoral end of the tube just by the side of it. You may also see fluid in the free fluid surrounding the adnexa. And not only that, you may also see blood inside, and because of that, you may also see the fibrin strands which you saw at the beginning of the clip. So these are the signs of early extrauterine pregnancy, or I would say tubal pregnancy for that matter. To add to this, gradually this outer isoechoic area starts becoming more hyperechoic. The central anechoic area may grow in the size, and sometimes you may also see sometimes you may also see inside some soft tissue echogenicities, which may be a yolk sac or the fetal pole. You'll also see the corpus luteum in the ipsilateral ovary, and both the ectopic as well as the corpus luteum are going to show you a rim of color. But it is the important differentiating point is this is extrauterine, which is the pregnancy, and this is extra-ovarian, which is the pregnancy sac or the gestational sac, and this is intra-ovarian, which is a corpus luteum. Still one more image showing the same ring of color. Some more images of ectopic pregnancy. You're seeing the uterus, the endometrium here, you're seeing the ovary, and this is the mass with the central anechogenicity and minimal fluid here. Again, a uterus, ovary, and you're seeing a hyperechoic outer ring with the central anechoic area, free fluid, again an ectopic pregnancy. Again, so, and this may be described as a Bagel sign. And this is where, again, a blob sign that you're seeing here. Of course, these masses may often be confused with other structures closely placed around the ovary, as I showed you in the previous image, the corpus luteum. Though they are very, very distinct from these lesions, which we often confuse the ectopic mass with. You can see hyperechogenicity. You are seeing a very regular anechoic area. Inside that anechoic area, you are also seeing tiny soft tissue. And in this case, you are also seeing a tiny heart beating there, which confirms your diagnosis of an ectopic pregnancy. Similarly, here also you're seeing an ectopic mass. But this may be confused with the corpus luteum, which again is irregular in shape, may show at central anicogaria, thick walls and ring of vascularity, may be confused with hemorrhagic cyst, it may be confused with luteinized and ruptured follicle. But we need to remember that it is these three signs, very typically they are truly intra-ovarian and they are not extra-ovarian, which is the main differentiating point between the ectopic and this. And we all know what are the signs which tell us the lesion is extra-ovarian. If you see ovary, you see the mass, you press the probe in and out and you see moving the two probes, two structures away from each other, tells you, yes, this is an extra-ovarian mass. Whereas if you're seeing mass lesion and you're seeing acute angle between the base of the mass lesion and the ovarian margin, or you were seeing peak of the ovarian tissue or the rim of the ovarian tissue surrounding it, tells you it is an intra-ovarian mass. So the first three can be differentiated just by this sign, sliding organ sign, or the peak and the rim sign, which tells you it is an intra-ovarian or extra-ovarian. Whereas sometimes you may see a bowel loop, and the bowel loop typically shows movements. The bowel loop typically shows movements, the peristalsis, which tells you, yes, it is not a tube and it is not an ectopic pregnancy and it is a bowel. If you rotate the probe, you will also see the long axis of the bowel and the layers of the bowel, which confirms the diagnosis. Hydrosalpinx, usually when you trace across, it will show continuity of the fluid compartments. It shows thinner walls. It will show incomplete septa, an elongation on the rotation of the probe, which are signs which tells you, yes, this is a hydrosalpinx and not an ectopic pregnancy. Using color Doppler, I've already showed you it, the ectopic is identified by a beautiful ring of color, which usually has a low resistance flow and a high velocity. It is the vascularity which suggests the viability of the ectopic pregnancy or the growing potential of the ectopic pregnancy, and associated ring of color surrounding the corpus luteum confirms that this pregnancy is supported by the corpus luteum. You may also sometimes see on the volume ultrasound, you may see a distended fallopian tube, which you can beautifully see here. I'm going to stop this clip. You're seeing the distended fallopian tube, and you were seeing the ectopic mass just by the side of that. Look, and with the minimal free flow, the distended tube, ectopic gestational sac at the fimbrial end. Similarly, here also you are seeing a picture on the 2D though, where you were seeing the fluid in the cavity. You are seeing a large distended tube, the fimbrial end, and you are also seeing a well-contained mass in the tube here, which is an ectopic pregnancy. One more image here, again a Begel sign. You're seeing again a distended tube here, and you're seeing a gestational sac here, uterus, ovary, and you're seeing a gestational sac again here. And in this case also, there is a very tiny gestational sac which is seen between the ovary and the uterus. And that tells you it is an ectopic pregnancy. Still one more, and we will not, and this is very interesting. See, many a times it happens that the gestational sac appears as a very tiny, not very specific mass, but there's a tenderness and pro-pressure free fluid, which tells you, yes, this may be an ectopic mass with a specific history. This is what you're seeing here. And you suspect a tiny gestational sac, though very difficult to convince others if they've not seen themselves. But after 3 days, you're seeing the mass being grown up, and there's also peripheral vascularity. Moreover, you can also use volume ultrasound, and if there's because there's a free fluid in the pelvis, it works as a virtual laparoscopy. You're seeing the uterus, one adenexa here, the other right adenexa here, showing a large mass and a blood-filled cavity, which confirms your diagnosis. Free fluid, which is seen in the ectopic pregnancies, is very important. It often contains blood and blood products, which we have seen, and we will not discuss here once again. You're seeing again fibrine strands. You're seeing the floating thickened tubes, and that tells you it is blood. Coming to other implantation sites, less than 5% of the ectopics settle into other sites than the tube. They're more difficult to diagnose. They have higher chance of bleeding and rupture, and they have higher morbidity and mortality. Ovarian ectopic, very, very rare, almost always hyperdiagnosed. Remember, it can be, corpus luteum can be mistaken for the ectopic pregnancy, but the major difference is the corpus luteal walls are almost never hyperechoic, whereas the ectopic pregnancy always has severely hyperechoic walls. And you may also see the gestational sac and the yolk sac inside. The hyperechogenicity of the outer wall confirms the diagnosis or is more suggestive of a diagnosis of an ectopic pregnancy in the ovary, though it is very, very rare, as I told you earlier also. The interstitial pregnancy is the pregnancy which occurs in the interstitial part of the tube, which is very beautifully seen on your 3D ultrasound, but it is quite beautifully seen even on your 2D ultrasound in the transverse section. And yeah, so here you're seeing the interstitial part of the tube, and if you're seeing a gestational sac somewhere here, that means on the line of interstitium, that tells you it is an interstitial pregnancy, but the line of interstitium will always not be seen. If you can see, yes, it is diagnostic, but otherwise you may have to depend on the on the other signs which will tell you which will differentiate an interstitial pregnancy from an angular pregnancy. And the most important is that the endometrial cavity is empty. There is a sac which is situated more laterally on the as you go from the mid-sagittal to the parasagittal sections. There may be an ecogenic, so that you may see a line of interstitium continuing from the on the transverse section from the outer end of the angle of the endometrial cavity towards the gestational sac. But even if you cannot do that, if you cannot see that line, the very important sign is that, and the most consistent, on your transverse section at the level of the gestational sac, a true transverse section, if you see the endometrial cavity, you're seeing a myometrial mantle, and then you're seeing a gestational sac. This is typical of an interstitial pregnancy. You can see the pregnancy here in the interstitial part of the tube. Whereas if you see that there's a gestational sac, and on the medial aspect of it, you are actually seeing the continuity of the endometrial cavity. As you are seeing here, continuity of the endometrial cavity, that tells you this is an angular pregnancy even here. This is also continuation of the medial the endometrial cavity on the medial side, and this tells you it is an angular pregnancy and not an interstitial pregnancy. The main difference between the two is the difference between the two must be identified very carefully and very confidently, because both have different prognosis. Interstitial pregnancy has a high morbidity and mortality, whereas the angular pregnancy is most of the times it grows inside the uterus as the fetus grows, and it may result into an abnormally adherent placenta, but usually doesn't have any very severe consequences during the pregnancy or later on, if correctly diagnosed. The very important sign that would help you confirmation on the laparoscopy would be on the angular pregnancy, there is a bulge medial to the round ligament, whereas in the interstitial, it is a bulge lateral to the round ligament. Coming to this cervical pregnancy needs to be differentiated from the pregnancy in the process of abortion. And remember that the cervical pregnancy is eccentric. It is not central in the cervical canal. It has peripheral vascularity. It doesn't change its shape with the peristalsis. And instead, if there is a abortion in process, it is central, no vascularity, and it is irregular in shape. There are some people who also say that there's a ballooned cervical canal, and this leads to a typical hourglass shape of the uterus, because the cervix also bulges and the fundus is also large. Uterine enlargement may or may not be seen, but the endometrial cavity is definitely empty, absent. Peripheral vascularity and absent sliding organ side confirms the diagnosis. Scar pregnancies, when it comes to our ears are raised, It is very important to diagnose it, but diagnose it correctly and don't overdiagnose it. It is an empty endometrial cavity, empty cervical canal. The gestational sac is seen in the anterior part of the uterine isthmus. There is no endometrium anterior to the gestational sac. There may be myometrial mantle anterior to it, but the distance between the myometrial mantle, the distance between the decidual reaction as well as the decidual reaction to the urinary bladder is definitely decreased, and there is no healthy myometrium between the bladder and the gestational sac. Because there's a very thin muscle layer left there between the bladder and the gestational sac, which is only about 1 to 3 millimeters, it has a high chance of rupture, and there's a lot of vascularity seen in this area. Negative sliding organ sign, tenderness and pressure are the important signs which tells us there's a possibility of this is a scar pregnancy. It may be divided into 4 grades depending on its size. It may be very small, just embedded in the inner half of the myometrium. It may be larger and it may cover more than 1/2 of the myometrial thickness. It may protrude out of the myometrium through the scar, or it may become just an amorphous tumor with a rich vascularity in the cesarean scar. But this is what you see when there is a pregnancy in the niche or in the scar. These pregnancies sometimes may be also described as a gestational sac over the scar or on the scar. And the basic difference between the two is what is seen here. You can see here that it is in the niche of the scar that the entire decidual reaction as well as the gestational sac are placed. And therefore, it actually separates the two myometrial layers, whereas when we talk about the lesion on the scar, you usually see either only the gestational, some part of the chorionic tissue invading into the lower part of the scar. It is not actually going into the niche and separating the walls. And this, again, just like the cervical and the angular and the interstitial difference, here also the pregnancy over the scar is usually, this sac is usually going to grow inside the endometrial cavity. It is not going to lead to any other complications other than abnormally adherent placenta, whereas the first one has a fatal outcome. Coming to the intramural pregnancy, it is very rare, usually needs an expectant management, or sometimes it would require a local methotrexate treatment. There's a typical history of a missed period, but the empty endometrial cavity, a hyperechoic decidual reaction like echogenicity, mass in the myometrium, very high beta HCGs, and even when this starts, it has a very high vascularity too. Even when it starts resolving after the treatment, it may still leave some products of conception and typically produces an enhanced myometrial vascularity. Abdominal pregnancies are not to be, I don't prefer to include them in this group because these are the pregnancies which are usually diagnosed very late unless the fetus grows, becomes very easily viable. There's no myometrial wall seen between the gestational sac and the skin. These are the things which tell us this may be and abnormal presentations is what tells us this may be an abdominal pregnancy. It is very rare and very difficult to diagnose also. So to sum up, ultrasound is a modality of choice for the diagnosis of ectopic pregnancy. It helps in confident diagnosis, accurate monitoring and efficient management. Volume ultrasound especially adds value in the differentiating between interstitial and angular pregnancy, confirmed diagnosis of cervical pregnancy, scar pregnancy, as well as multiple tubal pregnancies. Thank you very much for patient hearing.
Thank you, ma'am.
Thank you for the excellent presentation and discussion through your ultrasound videos, ma'am. Thanks a lot. Now let's move on to second session, decision making in ectopic pregnancy, medical versus surgical versus expectant. Now the chairperson for this session is Dr. Rajesh Bhakta sir.
Arun?
Can I
Yeah, Arun?
can I
Hello.
go ahead?
Yeah,
Yes,
yeah,
sir.
wait, sir. Just Arun is supposed, yeah. There is little this thing between screen sharing time. Yeah.
Rajesh Bhakta sir is consultant at Roshni Laparoscopy and Infertility Center, Udupi. Sir is associate professor during the years 2000 and 2012, Division of Reproductive Medicine and Surgery, Department of Obstetrics and Gynecology, Kasturba Medical College, Manipal. Sir has won many awards, Dronacharya Award 2024 at SR Bangalore, Legend in Gynecology at Wisdom Conference, Calcutta 2024, Shan S. Ratnam Young Gynecological Awardee at Seoul, South Korea, the Jogi Arach Rostam Irani Prize for the year 2007-2008 for the study on a randomized control study to evaluate the cost effectiveness in sperm extraction using carbon dioxide and carbon dioxide free system in IOI program received during the ASCOG held at Delhi. Foxy VHB Award during the 50th ASCOG in January 2006, Calcutta. Imaging Science Award 2003 during the 46th ASCOG, January 2004, Bangalore. Sir is member of Federation of Obstetric and Gynecological Society, Indian Academy of Gynecological Endoscopy, and Indian Medical Association. Sir is currently Honorable General Secretary, Karnataka Chapter of IOG. Over to you, sir. Sir, please kindly introduce the speaker, Dr. Parikshit Tank, and conduct the session. Over to you, sir.
Good evening, everybody. First of all, let me take this opportunity to thank the Kasoga President Dr. Rajeshri Palati and Prabha Desai, the Endoscopic Committee, for giving me this opportunity to chair the session. As we all know, ectopic pregnancy remains one of the most challenging emergencies. I think we are having every clinician should see whether should we trust methotrexate, when should we proceed to surgery, because we have all seen that the diagnostic modality has improved so much, the treatment options have expanded, so we should, having the real dilemma that whenever a patient comes and sits in front of us with ectopic, what should be the treatment which should give to that individual patient? That makes more important. So to answer all this dilemma, we have an expert here, a good friend of mine, Dr. Parikshit Tang, who is the co-founder for Pluro Fertility and IVF, is also a consultant at Ashwini Pluro Clinic and Center for Endoscopy and ART Mumbai. He is a consultant at Surya and many other places, almost 20 centers. He is presently the Deputy Secretary General of our FOXY. He was a chairperson for Safe Motherhood Committee. He is a clinical secretary for Mumbai OBGYN Society. He is an examiner and also a postgraduate teacher. He has won
Yes,
many awards.
I think I will spare you the trouble of reading everything.
Parikshit, I think I know Parikshit is I have to tell this that he comes from the family of presidents of Foxy. I think I can say that. Over to you, Parikshit, for the talk on decision making in ectopic, medical, surgical versus expectant. Over to you, Parikshit.
Thank you. First of all, I should thank Prabha for not only inviting me, which is always a pleasure itself, but also for selecting Rajesh as the chairperson for this session. I'm sure it happened inadvertently, but we happen to be very old acquaintances and good friends. I'll just start sharing my screen with respect and thanks to the Kasoga, to the office bearers. Dr. Shobha Gudi is logged in, I see. Dr. Rajeshri is there. So great to see all of you. Wonderful. And I'm going to talk about decision making in ectopic pregnancy.
Good evening, sir.
Hello,
Welcome,
hello, Dr.
Sugar.
Yes. Hi.
I would like to put it on record that one of the best conferences I attended was the Decoding Foundation conference way back in 2010. It was in Renaissance 3 days conference.
That's
Very
great.
great memories I carry of both Dr. Jaydeep Tank and Parikshit Tank of organizing a conference in the memory of the father. So when Rajesh Bhakta mentioned that it is a family of, presidents, just took me back to those days when such a lovely conference was conducted. Thank you. Over to you,
Thank
sir.
you. Thank you.
Hello, Parikshit. Good evening. Shobha
Hi,
here.
hi, Dr.
Yeah,
Shobha. Good
yeah.
evening. Good evening.
Welcome to Kasoga.
My
Welcome.
pleasure. My pleasure.
Yeah.
So much has been spoken about diagnosis. Dr. Panchal is the authority, the expert on ultrasound. But every now and then, ectopic pregnancies will surprise us. You know, they behave like a black cat on a dark night. It may make its presence felt in subtle ways, or it may leap at you, and sometimes it may just slip past unobserved. We have to illuminate the clinical situation and, having thrown light on it, decide what to do in those circumstances. Ectopic pregnancies can still kill women. This is a known fact. And if we look at maternal mortality in the first trimester, this is a leading cause of death. And deaths have been reported across all care settings. It's not as if women die only in rural areas where no diagnosis is there, no facilities are there. It's not like that. In those areas, of course, case fatality rates are high. They may be as high as 1 to 3%. But ectopic pregnancies will kill women when they are unsuspected, when they are undiagnosed, they are mismanaged, or one has waited too long on them to resolve. So I'll come straight to what tools we are going to use for our decision making. The first is, of course, a clinical evaluation. What is her general condition? What is her history? And what do you find on examining her? The second decision-making tool is the imaging. We want a confirmation that this is an ectopic pregnancy. We want the location, and sometimes ectopic pregnancy may not only be in the tube, it may be at so many other sites. And what is the size of that entire mass? We are interested in knowing what is the beta HCG level, not only the absolute level, but also the trend. Is it rising? Is it falling? By how fast it is rising? So on and so forth. So the first factor when it comes to decision making is the compromised general condition. By compromised general condition, I mean the woman is in a state where, as you can see in these CCTV video grabs, she's sitting 1 minute ago comfortably in the OPD, and in a few minutes she has collapsed and she's on the floor. If the general condition is compromised, the options are very limited. The bare minimum is you take a history, see if you can do a urine pregnancy test, and on the basis of that suspicion, you operate. What is desirable, if time allows, if condition allows, is imaging to confirm the diagnosis and blood work. But rapid action is needed in certain circumstances, and there's no time to have all the diagnostic modalities available in that particular situation. What are the history-based tools for decision making? And this takes only 2 minutes. When and how was the last period? Not the last bleeding, but the last proper period. When was it? Was it like your usual menstrual pattern, or was it something different? Have you had a chance to do a urine kit test at home? What's the nature of the bleeding? Did you pass a lot of clot or products? How bad is the pain? And are you feeling giddy, faint? Are any of these features there? These all can be thought about as precursors of the compromised general condition. Again, limiting our options. When you are examining this woman, what you're going to do is first look at hemodynamic stability. Is there tachycardia, hypotension, are any of these features there? Establish that she's stable. Then look for signs of peritonism. Peritonism means there is something inside the peritoneal cavity which is irritating it, and typically you will get rebound tenderness. And this is a very important feature. See, you can't keep repeating ultrasound. Sometimes a woman has come to you with a sonography done in the morning. You're seeing her in the evening. She may have ruptured in that interim. I think fornicial tenderness as a clinical sign is quite overrated. You can't make out anything because, if you ask a young first time pregnant woman on an examination, is there pain? She'll say yes, even from touching the introitus. So it's very difficult to make any hard clinical decision based on such things. Culdocentesis was something which was talked about in the yesteryears, but today it has lost its relevance. It's outdated. Don't bother to do all these things. Imaging, we had a very good exposition of the entire topic. Usually, if there is an intrauterine gestational sac with, yolk sac, fetal pole, etc., that kind of rules out an ectopic. Usually, I'm saying. Once in a while, you'll have an heterotopic, so there's always an exception to the rule. And confirmation is there by actually visualizing all these things outside, but there are gray areas. Either you have not seen anything, or there's some adnexal mass which you can't make out. And these things can make the diagnosis confusing, but if we have attended Dr. Panchal's lecture, we'll know how to distinguish and find out where we are exactly. Once we have made this diagnosis, the ectopic pregnancy is visualized. We want to know the size, location, and whether there is free blood in the peritoneum or not. And this is your typical flowchart. You look at things which will make you act very rapidly, things which will rule out and deem the condition safe, and things which will require certain degree of assessment. Now, when it comes to serum beta HCG as a diagnostic or a decision-making tool, what's important is that the result should be available reasonably fast. When we were residents, we used to send beta HCG. Then the patient used to collapse in the ward. We would operate. She would go home and then beta HCG would come after that. So that kind of a turnaround time is useless. If you're getting a report in a few hours, maybe 2 hours, 4 hours, then you can actually use it to make some correlation with the clinical condition and use it to make some kind of medical or surgical decision. If the diagnosis is not certain, especially in that kind of a situation, the trends become important, not just the absolute values. If you have a situation where the beta HCG is falling and the woman is quite comfortable, this is where I would apply a wait and watch approach. You can keep her on observation only, and usually the matter will resolve. If you find that the beta HCG is doubling within 48 to 72 hours, that signals a growing pregnancy. And usually that growing pregnancy is intrauterine, but it can also be an ectopic which is growing. What is worrisome and indicative of a problem is a small increase. Without visualization inside the uterus, you are seeing a small increase in the beta HCG levels. That is worrisome. So this is from Arias's textbook, a chapter which I have contributed in this book. Very clear, simple guidelines that are now validated across so many, so many organizations having given these things. For a woman who is not able to return for a follow-up, or who has one of these, that is hemodynamic instability, significant pain, a mass which is more than 3.5 centimeters, visible cardiac activity, or a beta HCG level over 5,000, offer surgery as the first line of treatment. Observation or medical treatment is not likely to work in these circumstances. For a woman who says that, yes, I am available for a follow-up, I will do the blood tests and the sonography regularly, and if needed, I'll come to the hospital soon. Provided she is hemodynamically stable, does not have any significant pain, the mass is small, less than 3.5 centimeters, then you go to the beta HCG level. Between 1500 and 5000, it's a choice, medical or surgical. We'll see the outcomes in the following slides. Less than 1500, offer medical treatment. Less than 1500 and falling, just observation. So this is the algorithm that can be used in routine clinical practice. If you're going to offer medical management, there are some considerations. Offer this methotrexate treatment only when the diagnosis is established, not for pregnancies of unknown location. That's not right. That's not the correct approach to the clinical situation. You have to meet the criteria. Just a single dose of systemic methotrexate therapy is what is recommended most of the times. Earlier, we used to give leucovorin. This is not needed anymore if you're using a single dose or 2 doses also. Leucovorin comes into the picture only when multi-dose methotrexate is given, which we no longer practice for an ectopic pregnancy. You must counsel these women about two important aspects. One is waiting time for future fertility. They'll have to wait for a minimum of 3-4 months before attempting pregnancy again. And there is a possibility of side effects of methotrexate. They exist. They're rare, but even that one dose of methotrexate can occasionally create problems. Should you decide to hospitalize her or keep her on an outpatient basis? Again, largely a question that has to be answered based on individual circumstances. What are your circumstances also? Where are you offering her hospitalization, etc. The important thing is that the time to intervention should be reasonably short, whether she's at home or she's in the hospital. There should be a very clear, defined clinical pathway that the woman will follow in case the situation changes. Now, why so much of an emphasis on beta HCG levels being used as a criteria? What happens is that as beta HCG levels are higher when methotrexate therapy is initiated, your success rates fall. You'll need more doses of methotrexate and the clinical situation changes, becomes compromised. So if you're in the typical criteria, then you're going to have a failure of medical methotrexate treatment only 5 out of 100. So it's a very successful kind of an intervention. Whereas if you cross the criteria, you're going to have 15 out of 100 women who will fail medical treatment or will need multiple doses, so on and so forth. Now, many argue that, okay, so what? Still 85 out of 100 women will avoid a surgery. Fine, fair enough. But then the 15 who will have a failure are likely to land up with an emergent condition, more likely to need blood transfusions, more likely to have a complicated surgery rather than a simple, straightforward, cold ectopic. So what are the contraindications to medical management? First, of course, if she's not meeting the criteria, if she's not able to follow up, not agreeable to medical management, don't do it. What are the contraindications to methotrexate? There are some which are absolute contraindications, like and coexisting wanted intrauterine pregnancy, or there is some immunodeficiency, she's breastfeeding. If, of course, there are other medical criteria like anemia, thrombocytopenia, she has a past history that methotrexate resulted in some problems. All these are conditions where you will not use methotrexate at all. How do you monitor? What is the decision making once you have initiated medical management? Then what do you do? As a baseline, you will have the beta HCG, do a CBC and a liver function test. On day 4, beta HCG rises. This is common, but that's not alarming. Don't worry, nothing much is going to go wrong over here. But on day 7, after methotrexate, the beta HCG should drop by at least 30%. If it has not dropped and the woman remains stable, no pain, repeat the methotrexate dose and monitor weekly. Don't do more than 2 methotrexate doses, provided she remains hemodynamically and symptomatically stable. So you may have initiated medical treatment with the understanding, having fulfilled the criteria, so on and so forth. But there are circumstances which will lead you to surgical treatment if no response in 2 doses of methotrexate or the clinical picture changes, switch tracks, go to surgical. I'll touch briefly upon atypical sites, and they are significant because there is usually a delay in the diagnosis. They behave differently from a tubal ectopic. Sometimes presentation is quite advanced and medical therapy is precluded. Surgical intervention is atypical, and everybody doesn't have an experience of dealing with hundreds of cervical ectopics. You may have dealt with hundreds of tubal ectopics, but not atypical sites. So these are difficult to handle. General tips: communicate, document, take the consent properly. Explain that there could be surprises. They'll not behave as usual. Here, I would strongly recommend to avoid passivity, be proactive in your management, and use the therapies with progressive levels of invasiveness. Be prepared for multimodality approach in this kind of situations. If you want to give medical therapy, that means you want to use methotrexate, same criteria apply. Same regime also applies, but the outcomes will vary. They may not always have a good response to the medical treatment. So you may need to perform interventions earlier in these situations. Ultrasound guided therapy can be practiced. The indications are failed or not suitable for systemic medical therapy. Beta HCG levels have plateaued, or as an adjunct to surgical or medical treatment in atypical sites of ectopic. It may be repeated also if needed. But if parameters are unstable, pronounced symptoms are there, don't bother with all this. You'll have to operate and have a definitive management only. You can approach the site transvaginally or transabdominally, whichever way is closer to the probe. And you can inject either potassium chloride or methotrexate. Both are equally effective into the site. In these circumstances, you'll have to operate if hemodynamic instability is there. And here I would really advise everyone, my suggestion is to not wait for things to get very bad, because this is not the usual type of surgery that you're used to doing. It's not amenable to medical treatment, forget it, just operate. But be well prepared in these circumstances. Where you do the surgery is also an important decision. Prefer a tertiary care place rather than a small nursing home where there is good infrastructure. Pre-plan these type of surgeries. Make a surgical plan how you're going to go about it. I've just put up this picture of a large cervical ectopic pregnancy. We thought that this is a scar pregnancy, but actually it was a cervical ectopic, and she came in a totally compromised state. Luckily, or however one may look at it, this was a third pregnancy. She had 2 children. And the only thing I could do was a hysterectomy to save her at that point. So it might be a very radical type of an intervention that might be needed in these circumstances. So they say, good surgeons know how to operate, better surgeons know when to operate, and the best ones know when not to operate. So you have to train yourself to be judicious and make the decision in the best interest of the clinical situation. Thank you all very much for your kind attention.
I think, Parikshit, you have touched every aspect of the decision making with regards to whether it is expectant or surgical, and very clear cut, defined whether it is ultrasound or beta HCG levels. I think that makes decision making very, very practical. There are some more questions I think we'll take at the end of this. So thank you, Parikshit. We'll meet you after the last talk. Thank you.
Sure. Thank you. Thank you, Rajesh.
Thank you for the insightful session, sir.
Pleasure.
We'll now proceed to our final scientific session for the day: laparoscopic management of ectopic pregnancy, techniques and tips. I request Chairperson Dr. S. Krishnavardhan, sir. Sir is practicing OBGYN at Guletgud, town of Bagalkot district. He is the pioneer gynec laparoscopic surgeon and OBGYN at Taluka Place since 20 years and changed the gynec practice scenario at an interior place of Bagalkot district. He has went against the flow of rampant hysterectomy in young women and encouraged the Save the Uterus campaign. I request sir to kindly introduce the speaker, none other than Dr. Prabha Desai madam, and take over the proceedings. Over to you, sir.
Yeah. Hi. Welcome, Dr. Prabha Desai, my good friend, and who has been pioneer in laparoscopy in Gadag district, and her fame has spread a lot all over North Karnataka, and she has a lot of professional affiliations, and she has her own RGHS fellowship in her institute, and at the same time she has won many awards, including the Golden Jubilee Award at Mumbai in 2002 and Foxy Pillars of Progress Strength Award by the Solapur OBGYN Society in 2025. And she is in laparoscopy, and especially in high-end laparoscopy like endometriosis. And I welcome her to the session to share her thoughts on the laparoscopic management. Thank you.
Yeah. Hello. I thank you, Dr. Krishnavardhan sir, for those kind words. Now I will just share my talk with the screen share. 1 minute. It will take 2 minutes me to share. 1 minute. I think my screen has been shared.
Yes, ma'am.
Hello. Yeah.
Yes, ma'am.
Am I clearly audible?
Yes, ma'am. Clear.
Okay. So, yeah, I'm very happy about Dr. Krishnavardhan has agreed to chair my talk. Actually, he is my very old good friend and my colleague also. And now, without much wasting time, I would like to just see this talk. I have a plan, like one topic will be elaborately discussed. So now we have gone through the diagnosis and the medical versus surgical. If suppose we go for the surgical aspect of the ectopic, what will be the ideal for each scenario of cases and how we should go for that, we are discussing in my talk. So as everybody has, previous two speakers has told about that, it is a very a crucial step in a woman to have an ectopic pregnancy, and it is a major gynecological emergencies, one of the major gynecological emergencies. And laparoscopy is a gold standard in hemodynamically stable patients. See, hemodynamically stable patients is which was previously constrained for the is now that word we have taken out, and we say that it is a gold standard treatment for all kind of ectopics, provided you should be expert in those techniques or you should be an expert in laparoscopy. But I will suggest for the beginners, you should you make a laparoscopy for your ectopic pregnancies when the patient is in hemodynamically stable. And our goals of surgery should be, first, as everybody knows, it's saving the life, then preserve the fertility wherever it is possible, and minimize the morbidity of a woman. So indications for laparoscopic surgery is, as we said, for the beginners, patient should be hemodynamically stable. For the experts, it doesn't matter. Then failed medical management or contraindication to the methotrexate or ruptured ectopic with a surgical expertise available. So if we see, as we say, as we know that majority of the ectopics are tubal ectopics. Okay, so what are the stepwise surgical approaches for all kind of tubal ectopics? These are the standard steps. Like when you take the patients inside the OT, you always patients see. Remember, I am just talking about the surgical aspect or laparoscopic view of all ectopics. So this thing is like patient's positioning and port placement. Of course, the preferred choice of anesthesia is general anesthesia for all ectopic patients. Okay. So after pelvic survey and identification of an ectopic is, even though you are thoroughly diagnosed on ultrasound, it is better to do a correct pelvic surgery and identify the sites of ectopic. It may be sometimes we have found that two sites ectopic exists at the two tubes also sometimes. So deal with the ectopic pregnancy first so that you can prevent the further blood loss in case of ruptured ectopics. Inspect the contralateral side so that you should not miss any other lesion in the contralateral side or contralateral side of the adenexa. Then decision of salpingostomy versus salpingectomy has to be made as per the type of lesion, where it is located, ruptured or unruptured, these all things. Okay, then aspiration of hemoperitoneum, hemostasis, and in-bag specimen retrieval. Don't forget to retrieve the specimens in bag. Okay, because it has got its own consequences. If you take out these pregnancies in bare without bag, you may have a persistent trophoblastic disease because we don't know the nature of that trophoblast which is growing inside. Then peritoneal toileting, including subchondriac region, and the chromoperturbation if the patient is interested in further fertility. So this is a small video of standard steps of tubal ectopic. This is a case of previous one LSCS with a ruptured tubal ectopic, just operated yesterday only. And see, she has got a large clot and a bleed. It was a whole of the tube has been involved in this case. So there is no chance of preserving her tube in this condition. She has got a ventrofix uterus also, and the other tube, when we have inspected the contralateral side, the other tube looks normal. But we have noticed, you might have noticed that there are actually a small tubercles on the other tube. So decision for salpingectomy has been done, and the total tube has been knocked out. See, while taking out the tube, when you are doing a tubectomy in case of ectopic pregnancy, when you're taken a decision of salpingectomy, never do a partial excision of the tube. Okay, that's a very dangerous. The patient may come with a stump ectopic or the corneal ectopic again. So when you think that there is a small bit of the tube has been remained, you just go and take out that part also. But don't do over charming of the cornea, otherwise that cornea will become very thinned out and may rupture during the next pregnancy. And take out all the products, suck out the peritoneum, and if you feel that there is clots are remain and which you cannot suck out, take out all those clots inside the bag, and then take out the black out of the abdomen and retrieve the specimen. And don't forget to, once you give head, all the blood drains out into the upper part of the abdomen. You just suck out all the blood so that you will prevent the adhesions further. And then after doing a thorough peritoneal lavage, do the chromoperturbation. I always do chromoperturbation if the patient is desire for the further fertility, so that I can give a clear-cut view to the pregnancy for further to the patient for the further fertility view, and then treat her cause for this ectopic so that she will not have a recurrent ectopic. Okay, then as the 10 mm ports and 5 mm ports should be placed as per the need for that patients. There, it doesn't matter 2 or 3 side ports you are using. Then hemostasis techniques is always don't operate without bipolar coagulation. That is a basic rule. Then vasopressin. See, this talk has been prepared keeping in mind of the all budding gynecologists also and the fellows also. So I may go into small, basics also, basic steps. So here, so vasopressin infiltration, whenever you feel, we can use a diluted 10 units in 100 ml of NS, and then you can use the vasopressin infiltration when you are, especially when you are doing a salpingostomy and want to preserve the tubes. Then intracorporeal suturing, you should know when you are dealing with the corneal ectopics or you are dealing with the complicated cases like cervical or scar ectopic to suture the uterus and the corneas. Then hemostatic agents, whenever it is needed, is I usually don't use much. And you should be very thorough when you are operating about the anatomy of the uterus, and when you are dealing with the complicated cases of ectopic, should be very thorough in anatomy. Why? Because you may need temporary uterine artery ligations to save the uterus and to save the life of the woman. So this is case of one woman where actually she has come with the first time with a left side ectopic, and they were very keen about, she had a previous one missed abortion and they wanted to save this tube at any cost. And she was one of wife of one of the medical field professional. And then he said that no madam, I will he was not ready to give the consent for salpingectomy. So I just see, you can notice there are the tubercles also. Still, in spite of his insisted, so he has not given the consent for salpingectomy. I just done a milking of the tubal pregnancy, and with milking the whole of the ectopic pregnancy, I could successfully take out, and it looks too rude. Sometimes we feel that, we are damaging the more damaged tube, and it's a tubal endometrium. But in situations where the patient is not willing for self-injective, we cannot go ahead. Just take the consent that she may have a recurrent ectopic on that side, okay, or in the and if they are willing for that, then only you can go for the such procedures. After doing the milking of all the products, I found that the tubal mucosa is intact there, and there was a little tear at the serosa. So I just sutured those serosa, sorry, not serosa and the mesosalpinx, and then just done a peritoneal toileting and came out, and we have given her AKT after doing her, by seeing her clinical diagnosis. After receiving AKT, she was, again after few months, she came with the repeat ectopic pregnancy. But that time, this was not in the right, in the left tube, it was in the right tube. Okay. So again, after her, that time also actually they were not at all willing for the salpingectomy. They said that that time it was on the left side, now it is on the right side. Please do the tubal conservative surgery itself. And she was very lucky that it has been diagnosed in very early stage. I tried doing conservative saving these tubes, but I found that the tube is too much of involvement of the tubal, means almost more than one third of the two-third of the tube has been involved, and her mucosal status was also not so good. So what I've done, I have done her to convince the patient's relative. I have done her chromoperturbation also to look for the other side tubal status, and that other side tubal status was actually good, which we have operated previously by milking the tube. And then see, this was that the same tube after the 1 year of the milking, and the tube was patent, but we found that there are some adhesions and all. But still, as they were this thing, after convincing that one tube is okay, now we don't want you to go for third time ectopic. So I just knocked out her this affected left side tube, and after again is and I told them to go for the IVF pregnancies to take a chance for that. And while waiting for the IVF, she has conceived within 4 months intrauterine, and she delivered recently with 2.8 kg female child. So this is sometimes gives a reward, but you have to take a patient's consent, and you should know the techniques of tubal conservation in case of ectopics. So this is about only this thing about the milking. But what about the salpingectomy? Everybody know when you are doing the salpingectomy, we should be very see, this is a case of chronic ectopic. When you are doing a salpingectomy, you should, whatever may be the size of the tube, you should be very close to the tube. Otherwise, you may hamper the vascularity of the ovary. So stay as close to the tube as much possible. Okay. And then try to take out the tube in toto. Complete tubectomy has to be include up to the cornulent. Okay, this was a chronic ectopic case where she has come after 3 months of having a pregnancy test positive, and you will get surprised. How come? I was also surprised. How come that pregnancy has not ruptured? Might be she is having a previously hydrosalpinx also, and in that you can see this already limb has formed, and still the tube is intact and that was ruptured. So sometimes chronic ectopic, when you are dealing these times, there is no any choice. You have to go for salpingectomy only. So what about the salpingostomy versus salpingectomy? The choice depends on the fertility desire, condition of contrarectal tubes, and the extent of tubal damage, and the surgeon's expertise and patient's stability. So salpingostomy is a linear incision over anti-mesenteric border, removal of the products of conception, and you give a thorough hydrodissection through suction irrigation, or you can do a chromoperturbation like test where it will drain out the remaining products. And then secondary healing of the, you allow for the secondary healing of the tube. This is one of the video of salpingostomy. Actually, this case actually we have posted for diagnostic histolaparoscopy, and we found that there is actually a small ectopic pregnancy which was diagnosed on HLscopy. That's why that histoscopy video is also there. And then when I was inspecting for her this thing, I found that there is a tubal ectopic, and on table actually, sorry to say, on table this patient has been done a UPT and that came positive. This happens sometimes because when you give date for this month, the patient comes for the next month for the diagnostic histolaparoscopy, and they tell that they have got a menses on this date. Actually, that might be a spotting PV. So this is a salpingostomy video where we took the incision and use a very minimal bipolar cautery here. Okay, and you will take a assistance to taut the tube, target the area and take out the all products. See here, chances of persistent trophoblastic disease is also high. So you should be thorough that you clear out all the products, okay, and give thorough wash. And I made a point that just closing this was very small, so I just closed the tubal lumen and then I checked the tubal patency by putting the dye, and that tube was actually patent there. And after a few months, she got conceived intrauterine, but I don't know which tube has functioned her. But if the patient wants the fertility and the tubal, wherever is possible, you can try to save her fertility by saving the uterus tubes and by taking a special consent. So this is about the salpingostomy. So what is the advantage of salpingostomy? Is potential preservation of fertility usefully in contralateral tubal disease and tubal conservation approaches. Disadvantage is persistent tropoblastic tissue chances are there, need for serum beta HCG follow, and risk of recurrent ectopic pregnancy is high, so you have to take the consent, special consent. So how about the manage? We should go about the ruptured ectopic pregnancies, rapid suction evacuation of suction of hemoperitoneum, secure bleeding pedicles early, careful tissue handling, and timely conservation. We should save the time of diagnosis to the surgery. That time should be made very, very less. So this just now what we have seen one ectopic pregnancy, it is like that only. Only we are worried about if it is a acute on chronic and lot of clots, you may have to use a large bag. Sometimes we use a Euro bag to take out all the products. That much of clots they will be having. Then complex ectopic pregnancies, as we know, there are so many complex ectopic pregnancies we are coming out. We are dealing nowadays because of this all corneal, interstitial, and ovarian. Of course, I have till my obstetric career only 2 cases of ovarian ectopic I operated, only 1 heterotropic, but rest all cesarean, scar and all we are getting nowadays very often cases. Then cervical ectopic also we operated 2 cases. Interstitial pregnancy, then heterotrophic pregnancies, these all are complexes, and their surgical principle of all such cases is unique for each ectopic. So we should know main is hemostatic sutures and how timely we should use those techniques for each case. So if you don't well verse about those, then the excess bleeding is one of the danger problem in case of like cervical ectopic or scar ectopics. Then persistent trophoblastic tissues is also a second issue. Thermal injuries may happen in case of emergencies when you are not well versed, or if you are in tense situations when you are operating with multiple, with bipolar, with harmonic, if you are keeping 2-3 devices, cautery devices, the chances of thermal injuries are there. The need for conversion to laparotomy, we should always keep in mind. If you find that it is going beyond the control of laparoscopy, either you can do immediately open the abdomen and then control the bleeding. And sometimes I go, if like in case of scar ectopic, cesarean scar ectopic, if we find that we are not finding the lower edge of the uterus to suture the abdomen and the hemostasis is going difficult, I go sometimes vaginally also open the pouch and then hold the lower edge and upper edge of the uterus and then suture from down. So you don't be adamant when the situation is going beyond your hand. Then corneolar interstitial ectopic is implantation in interstitial part of the tubes, and usually these patients presents late due to the distension. Availability of the myometrium is very high here. And diagnosis, as madam has already told us, these cases bleed very high. So if in very early cases, you can use a methotrexate or corneal resection, corneostomy, and laparoscopic suturing of the cornea is one of the modalities. So surgical tips here is use of vasopressin. It will save the blood loss. Then bilateral temporary uterine artery ligation technique, you should be you can use that thing. Then minimal electrosurgery is, I told, when you are working at the cornu, why we should be well versed with the suture, because we cannot use judicious electrosurgery here, otherwise the patient will have a rupture uterus in next pregnancies. Then secure the multi-layer suturing technique. So this is one of the corneal ectopic patient which has been diagnosed in male. Okay. See, this is a corneal ectopic is bigger than the uterus fundus, uterine fundus, and it was so scary. We have done a prophylactic bilateral uh, temporary uterine ligation. Okay. So after in this video, I will show the complete temporary uterine artery ligation technique, and in other things we will show. Posterior approach. So this is bilaterally the uterine artery has been ligated temporarily by the posterior approach with a victory. Okay. And then vasopressin has been injected into the, you inject the vasopressin into the uterus, okay, not into the ectopic, because the bleeding surface is from the uterus, blood supply is from the uterus, and this circumferential stitch has been taken so as to I could demarcate the cornu also, and plus it will help in hemostasis. Then take the incision. Okay. Here, of course, you cannot save the tube in such a big mass. Okay. Take out all the products. Don't see here the chances of okay, after taking all the products, you wash and then close in 2 layers. Okay. Once you are confirmed with hemostasis, do a peritoneal toileting. Okay. And this patient, then take out the tube because it is of no use, and then release the both uterine sutures. Check for the bleeding again. Okay. Then thorough wash, and I'm happy that this patient came after 3 years with a spontaneous conception, and she delivered a 3.1 kg male child. And this was her corneal status during cesarean section. I think 3.75 kg something. And this was her corneal state during her cesarean. If you follow the surgical principles of every ectopic pregnancies, the chances of complications during the next pregnancies are very less. Then cesarean scar ectopic is also one of the challenging thing. Nowadays, the rate is increasing like as the increasing the cesarean section rate, and I really am taken my motto as to how to, do a proper cesarean and take care of the cesarean scar so that it will not form a niche further, or it will not have a so many post-cesarean complications we are finding. Those complications, how to prevent and all, I am coming with those workshops in so many other societies. So let's see how that will impact on our budding gynecologists also. So this is diagnosis part has been covered. Usually these patients come, if they start bleeding, it's a severe bleeding, and you within time, no time, it will not give much time for once it ruptures, it will be in liters, not in mls, and then if it is usually it ruptures at the scar site, and or it may grow inside causing a placenta accreta syndrome. So management methotrexate has got very little role. If it is a very small early, histoscopic or laparoscopic excision is advisable before rupture itself. Then combined approaches is sometimes possible with uterine artery embolization and along with laparoscopy kind of thing. Then surgical pulse is here bladder dissection. You should be very thorough in bladder dissection when you are going for laparoscopic management. Then scar excision has to be done thoroughly. You should excise the whole scar along with the tissue, and then myometrial repair has to be done. This is a case of history of MTP at 13 weeks of gestation followed by recurrent like bleeding, spotting for almost 1.5 months. And then she has been referred for us after the ultrasonography. Actually, her whole baby has been expelled, but her placenta was inside the scar. On this is her ultrasonography. When we have done her histoscopy, we could not find any, placental tissue inside the uterus. The only we can see hyperemic and vascular area in the uterine cavity, and that's your anterior wall. And this was her uterus, where the uterus was completely thrusted to the anterior abdominal wall. It was a completely ventrofix uterus. I was finding a space. Actually, only with the histoscopy itself, the patient has torrentially bled, and I have to put her Foley's inside the intrauterine cavity, and then I proceeded to stop her bleeding, and then I proceeded with laparoscopic procedure. And I was knowing that she will bleed torrentially, so I had just done a bilateral temporary uterine artery ligations at the origin. And this was actually her tube, which was a swollen and hydrosulfing. So I have gone on the left side with the posterior approach. Okay. And then with the posterior approach, when you find that the anterior approach is difficult, to go to the posterior approach and then ligate the uterine artery. Okay. So you should know both the techniques of anterior and posterior approaches when you are dealing with the in such situations. This intrauterine Foley's has given me a time to do this procedure. Then you have done a bladder dissection. Once you dissect the bladder completely, then you take an incision over the bulge part of the uterus. And this was actually a retained, you can see the Foley's, intrauterine Foley's, which has been inflated inside. And this whole is a retained placenta of 13 to 14 weeks of gestation. After the expulsion of the pregnancy might be, no, if it would have continued, it would have become a placental topos, this thing, persistent placenta percrita kind of thing. And then the uterus has been closed in 2 layers, and then tubectomy has been done for this patient. So this is, you should predict which patients will have a problem of bleeding, and then take a proper precaution prior to dealing with the exact lesion. Okay. So why the bilateral self-injectomy has been done for this patient to prevent the further ectopics or further pregnancy. Just fast forward here. When bilateral sutures has been taken out. So this is actually a case of, this is a follow of that patient after 2-3 months. Their uterine scar and everything was okay. So cervical ectopic pregnancies, most of the times, as Madam has told you, will be misdiagnosed as a collapsing pregnancy, or it is an incomplete abortion and the pregnancy has come down of the means pregnancy is expelling into the lower part of the cervix. So such same thing has happened with these patients. Actually, that patient has been referred to us with saying that a cervical fibroid with a post DNC having a spotting PV. So if, out for that patients, I could not have tried with methotrexate or KCL injections or uterine artery embolizations. So I have done a laparoscopic method. And actually that patient has underwent 2 times DNC saying that first time they could not get the complete evacuated. That's why second time they could not get any RPOCs, but still patient has got beta HCG little raise and having a spotting PV, and this was her ultrasonography, and it was confusing with actually fibroid, cervical fibroid. And then this patient, when we have operated laparoscopically, this again the fundus and everything was normal. There was a little posterior bulge at the cervix. Again, bilateral uterine artery ligation has been done. And sometimes we do the internal iliac artery ligation also. If you find that there is, you cannot approach the uterine artery at the origin, you can, and a lot of hemostasis is needed. You can ligate in such cases. Internal iliac artery anterior division at the origin. Here clips has been used. You can use a temporary clip and then take out them. Okay. So here, right, both the uterine arteries has been clipped. After clipping, I have used a hysteroscopic approach. Hysteroscopically, now I am sure that the chances of bleeding is less. So hysteroscopic, all products of conceptions in the cervical canal has been taken out. This is an empty uterine cavity. And this is post-evacuation dilated distended cervical canal, and mostly this is the internal loss, and this is a dilated distended cervical canal. Post-evacuation, to assure that it has been completely evacuated. Okay, so this kind of heroic things we have to do, like multiple approaches we can use, like hysteroscopic or laparoscopic. This is one I think we are running the short of time, so I will just show. This is a corneal, this is rudimentary horn pregnancy ruptured at 16 weeks of gestation, and this patient has been referred to us for the CT scan to our unit, to our hospital. But in the city, while by one surgeon thinking that there is some mass in uterus, and then in the CT scan table only she collapsed. Her HB was hardly 4 gram or 3 to 4 gram, and we have to do her emergency laparoscopic surgery and excise her rudimentary horn, take out the almost 13-14 weeks of pregnancy, and then saved her life with a massive blood transfusion. And after a few years, she conceived herself after 3-4 years, and this was her intra this thing during cesarean section. She delivered 2.4 kgs female child. So this are the then heterotropic pregnancies as increase in ART and IVF conception. These incidences has also increased more. You should keep in mind, whenever you do intrauterine pregnancy scan, you should search for adenexa so that we should not miss these things. And this is the last video, I think. Then entrapped RPOC at the niche. Sorry, it is not interstitial, it is a intramural kind of thing actually. So it is very difficult. Actually, this patient has underwent DNC first time, and they have taken out the previous one LSCS. Her suction evacuation has been done, and followed by she is having a recurrent spotting and foul smelling discharge. Then when scan, it has been done on the scan. Actually, I could not put her scan image here. There was a still in the anterior wall of the uterus at the niche area, some written products kind of thing was there. So when I went for the hysteroscopic approach, I could see here that that pregnancy has extended into the myometrial layer, Okay, and the products from there, how the Sonal madam has explained, if it is a niche pregnancy, it may separate the niche wall and then the products may enter into the myometrium and it may become like an intramural pregnancy. It is not an interstitial, actually by mistake it has been mentioned here interstitial. So here, like a intramural pregnancies, if it is a small, we can go like this by histoscopically and completely empty, and ultrasonography is also needed to guide from above whether we have completely taken out all the products at the niche area or not. And this patient, we always advise them to have a relook histoscopy and ultrasonography follow-up. If that niche area is defect is more, before going for the next pregnancy, correct it by laparoscopically and then allow them for the next pregnancy. So this is her actually complete evacuation as done by histoscopically. We need histoscopy, laparoscopy and ultrasonography guided evacuation of such pregnancies. So presence of intrauterine pregnancy does not exclude the ectopics, and TVS is essential tool. Laparoscopic removal of management always remains laparoscopy is a gold standard. Then ovarian ectopic pregnancy is, as we have seen, it is very rare, but still when it happens, we usually it is unruptured, then it will give us a time like a wedge resection you can do, or take out the like a cystectomy, take out the all products, and then don't forget to take the suture and then repair the ovary. Otherwise, it will bleed a lot. It's very difficult with the cautery to have a hemostasis, and we cannot afford to burn the ovary. And so my take-home message is early diagnosis in case of ectopic improves the outcome. Laparoscopy offers a faster recovery and less morbidity. Individualized surgical decision making is very much essential, and sometimes we may change the on-table management decisions depending on the situation and locations. Then meticulous technique prevents the complications. Laparoscopic approach is a gold standard in experts' hand in all type of ectopics. Thank you one and all. Hello, Srisha.
Thank you for the wonderful insights, madam. And thank you for the wonderful videos for presenting
Wonderful.
laparoscopy pictures too.
Lovely, lovely presentation.
Thank you, ma'am. Thank you, ma'am.
Your sessions are over or you still have?
Yes, ma'am. No, only question answers, 2-3
Question answers.
Rajesh has something to say. Yes, Rajesh.
Yes, sir.
No, I just want to congratulate all the three speakers who have beautifully covered all aspects of ectopic. I think there are few questions I just want to take it from the chat box. One of them is, I think it is for Parikshit. I think he has answered, but however, is Parikshit there?
Yeah, I think he's there.
Anyway, it's just the newer modalities of medical treatment, that is adjuvants along with the methotrexate. I think that is letrozole as additional to methotrexate. Is there anybody who has experience on this, or Parikshit, you can give some inputs on this?
So what is, I think I'm just connecting with Parikshit, sir. Do you have any experience you can share, sir? It's open for discussion.
No,
He will join.
I'm not been
Rajesh,
using
have you
letrozole
used
at all.
letrozole? No, I have also not used.
No,
Net slow aitordu.
Hello, volume. Somebody's. Hello, Arun, please unmute the others.
I think one more question.
Hello. The methotrexate, apart from methotrexate, as in letrozole and all are nowadays they are using more for AVM cases. But AVM is nowadays more, overdiagnosed things. I feel.
Slightly overdiagnosed.
Yeah, slightly
And I think
overdiagnosed.
AVM responds very well to hysteroscopy and removal,
Yeah,
and
ma'am.
my patients have not required any medical management.
Yeah, but
I've done
real
about
case,
3 hysteroscopic removal of AVMs. I mean, neither is the vascularity very high when it is seen on Doppler. Definitely, history of miscarriage is there. That RPOC type of picture with some vascularity is there. But after 3-4 months, also they have not shed it. They go on having AUB. We do hysteroscopy, and it usually solves the problem. And we
yes,
put them
ma'am.
on some contraceptive pills or something so that they have contraception as well as regular bleeding. So,
So
do you
what's
have experience of letrozole for AVM, Dr. Bhakta? No.
No, I'm not using it all.
madam,
Correct.
almost over, madam.
One
Can
thing I
yes,
wanted
yes,
to,
yes,
one input I
yes, madam.
wanted to
Thank you,
give.
ma'am. Thank you. Yeah,
Yeah,
yeah. Hello. Yeah.
yeah,
So
Prabha.
any questions for Sonal, madam?
Tell
Madam
me,
is
tell me.
uh, hello.
Yes.
Yes, ma'am. Madam,
Sonal is still there online.
yes, ma'am. How you, this is from my, how you diagnose that, sometimes it is very difficult for ovarian, the corpus luteum, and immediately side by there is a very small ring which you have shown there. And if the patient has taken beta HCG injection without knowing, one case has been referred to us like that. She has received a beta HCG 4 days back, thinking that it is a intrauterine pregnancy.
Yeah, so there are only two things which will
And
definitely
her beta HCG has actually, she has received 5,000 units of beta HCG and her beta IM injection. And this was previously, they thought of chemical pregnancy, then they thought of intrauterine pregnancy, then they have referred to us after giving beta HCG 4 days back. So it is very confusing how to correlate her beta HCG level with this sonography finding, where I am finding only 2 centimeter mass with a very tiny 5 to 6 mm GSAT.
you don't actually need to correlate also with beta HCG, because when it is about ectopics, the beta HCGs always do not correlate with the sex size and the status of the pregnancy. But what is important is when you see that there is an intra-ovarian, I mean, when you suspect ectopic, you're first going to definitely rule out the tubal ectopics.
Yes, ma'am.
And after that, Charamat you suspect tubal ectopics, you rule out tubal ectopics if there is no extra ovarian mass in the adnexa. But you have to be very, very careful when you are searching for it. As I told in the presentation, the first thing is you have to keep on thinking about ectopic to diagnose an ectopic. If there is nothing extra ovarian and you are expecting you suspect an intra-ovarian mass to be an ectopic, that is when you just have to see two things. One, there has to be a CL and there has to be a gestational sac both in the same ovary. One. Second is that the one of the two has to have hyperechoic walls. The second has to have hyperechoic walls, and the major difference between the corpus luteum and the gestational sac is corpus luteum 99% of the times it will not have hyperechoic walls, it has isoechoic walls, whereas the ectopic pregnancy will have hyperechoic walls, and that is the major difference between the two.
Yes, ma'am. Because we being a surgeon, we always see after the early diagnosis cases are very less with us. We
No,
always
otherwise
think they
also
are
ovarian
already,
ectopics,
yeah.
99% of the time ovarian ectopics are overdiagnosed.
Yes, ma'am. But if it is
Yeah.
a tubal, we can give like 3 to 4 days space and then repeat the scan. If
No,
it is,
even if you do that, not all ovarian ectopics will be increasing in size. They might not be
oh, okay.
as active and as growing as ectopics elsewhere.
Yes,
So there are two things. One, as I told you, one is two lesions in the same ovary,
yes,
and one which is showing hyperechoic walls, and the second which is isoechoic walls. Both
sure,
will
ma'am.
show ring of color.
Yes, ma'am. Any other questions? Srisha,
Ma'am,
madam, anything in
there is
the
one more question, ma'am, regarding
Yeah,
dose
tell
of
me.
methotrexate. Single dose versus double dose. Is the dosage same for both? Multi-dose methotrexate therapy, single dose methotrexate therapy. Is the dosage same?
I think this question is for Parikshit sir. He is not there.
I
But
think he has
Rajesh sir?
already answered the
yeah,
question
yeah.
for
It's
the
not
hat.
answered
Yeah,
properly.
see, usually it is a the dose is like
1 milligram per kg
per
meter
kg.
square.
No,
Yeah,
no, he is not answered properly, Prabha. Rekha here. See,
yeah.
that is the dose what we give for the alternate days or when you are doing a continuous therapy of methotrexate. He
Yes, ma'am.
particularly mentioned that it is for a single dose. So that is
Okay.
why I asked for single dose, whether you will give a like a bolus dose or some massive dose in the initial and then wait. And that is not to be done because you give per kg body weight, calculate and give
Yes,
because you
ma'am.
know
Yes,
that
ma'am.
it has its own side effects. So that is why I particularly asked, but his answer was not clear. He mentioned as though we are giving it regularly what we give, the alternate days.
No,
That dose he
madam.
has mentioned, Rajesh.
No. Usually, madam, if we give for repeat also, we have to give the same dose.
It is the same dose, Prabha.
Same
No,
dose,
Can I
madam.
come in
so
here?
what is the difference
Yeah.
between
So when we are looking at medical
doses?
management of ectopic, see, majority of women resolve with a single dose.
Yes,
If
ma'am.
they are not resolving, they are going towards growth and near rupture and you are operating. Okay. But when they are resolving, it is majority of single dose. But on couple of occasions, we have used a repeat dose. And that is when the beta HCG has not fallen adequately in 48 hours. If it has not fallen by more than 15%, then so here beta HCG has a role to play. We can can keep a clinical track and an ultrasound track to see if there is any impending rupture. If it is not there, we can keep a track on beta HCG. If the fall is more than 15%, we can wait. If the fall is less than 15% in a clinically stable patient, ultrasound remaining the same, we can repeat the dose of methotrexate. But when we give the second dose, it's imperative we can have some kind of blood tests and tell her about other safety like being in the hospital. So whenever we have done that, we have kept the patient admitted and seen that any people with infection do not come in proximity. All those things may be over precaution. And also we give the folinic acid rescue mandatorily.
Yeah.
We give the
If we are
rescue
using,
for both for
what
the
I'm
first
saying.
dose. It is better. So, yeah, Rekha, yeah.
madam,
Yeah.
actually, no, with I have seen one patient with methotrexate sensitivity, not contraindication, not contraindicated patient, normal patient, and
That
she
can
herself
happen.
was ophthalmologist, and she
Mm.
had one dose of methotrexate, and she went into on ventilator. So this
I
kind of
hope she recovered.
yeah, she recovered, ma'am. She
Mm.
recovered, and after that,
Anaphylactic
she
shock can
delivered to
happen. My God.
not
It can
anaphylactic, madam,
happen.
not anaphylactic shock.
Huh.
It was
Huh.
her effect of that is a separate entity than the contraindication of methotrexate. Some patients are
Well,
sensitive to
you said
methotrexate.
hypersensitivity, no?
Not hypersensitivity,
Hypersensitivity,
not
no?
hypersensitivity that will act overly into their liver, ma'am. And
I
then
know.
our liver
That is what
problem
madam
will
is
come.
telling, hypersensitivity. So
Yeah.
their action is much more than what is
The
normally.
That's
normal.
Hyper
The
what I'm
They are
cell
responders.
damage is more
hyper
in those
responding.
patients.
Hyper
Yeah.
responders. No, what I am saying, Prabha, is entirely different. So that means there is no entity called single therapy, right? You
Madam,
give one.
single therapy is there actually.
That is
Single
different.
therapy is there because we do all criteria we see, no, madam, whom to.
In that
We
case,
usually
dose
give
No,
in
is
early
different.
single
stages. There
dose.
are criteria.
Single dose is enough most often, is
Enough,
what we are
madam,
saying.
most of the
Yeah.
times.
Exactly.
Yeah,
Single dose
because
may
I
be enough
have
and
a
then you
experience of
watch.
But
medical
there is nothing like
management.
a standard single dose. When we
Exactly.
float the
Exactly.
treatment, we never offer it as a single dose. We always
Maximum we
counsel.
can give 3 doses at
Yeah.
on the first day, then after 3 days of repeat, fourth day, then seventh day. We can give
Yeah.
maximum
1,
three
4,
doses.
and 7. 1, 4,
1,
and
4,
7.
and 7.
Beta HCG should be also done.
Yes,
And we
ma'am.
can check. Yes.
I have a few patients with that. Yes,
Yeah,
ma'am.
that is what I'm saying. 1 minute, please allow me to talk. This is exactly what I have been telling. There is nothing called single therapy in that case. It is just give the first dose and then watch. He was particularly mentioning about single therapy, and that is why I asked the dose. Okay, thank you.
Yes, ma'am. Yes, ma'am. Means
Prabha, I had one input about recurrent ectopic. Somebody is asking a question, let them ask.
Rajesh, madam wants, I think time is more. So Hello.
Hi,
The
Rajesh.
thing is that with methotrexate, a single dose, I had a patient who came with the entire hair in her hand.
My God.
Okay, she had a fall of hair. Yeah,
Mm.
and it was so scary that we
Mm.
had to do a lot of counseling, and thankfully she grew her hair. One thing, and second thing, in case of recurrent ectopic pregnancy, do you need to stress upon doing the investigations for infections, because many times chlamydia, the causes for ectopic pregnancy, and in the absence of previous surgeries and other issues, then chlamydia becomes a very important aspect. That is there any practice of resorting to giving antibiotics in each cycle for 2 to 3 cycles? Because the RCOG had some guidelines of investigating for chlamydial infection and also.
Madam, more than chlamydial in our scenario, if you, hello, Madam, your
Yeah, that azithromycin, does it have any role in the prophylaxis and prevention of recurrent ectopic pregnancy?
Madam, it's very difficult to diagnose between the tuberculosis and the chlamydial sometimes. So, but
Yeah.
seeing our Indian scenario, we have got more of the tubercular genital cox patients rather than the chlamydial. So here, if you find the tuberculosis and all, most of the times, if you have a one ectopic and single time, and if you have a telltale sign of tuberculosis there, I usually put on AKT saying that clinical ground, and that has been accepted. In fact, you can go for retrospective diagnosis after putting AKT if the signs came back. Then we
Correct.
put
So
that.
it becomes important that we evaluate for tuberculosis and chlamydia also to prevent the
That's
recurrent
one more
infection.
advantage of doing a laparoscopy in
Laparoscopy.
case of, yes, ma'am, in case of
Yeah,
ectopic.
yeah. I think we can wind up with this. It is
Yes,
already
ma'am.
7 o'clock.
Thank you, ma'am.
It
Yeah,
is
so
a
I
very,
just
One
very
more
nice.
question is there, ma'am. Why do we need to ligate uterines rather than why can't we coagulate them?
see, it is a temporary ligation of the uterines we do so that it will be better for the fertility of the patients. Okay, if you are not well versed with ligation, you can go with coagulation also, but we don't want to have a further
No, I think it
fertility
will,
issue in
coagulation should not be advised,
yeah.
Prabha, because
Yeah,
it
yeah,
does
ma'am.
not damage only at the point. It isn't extends beyond the point
It
of
is like
coagulation.
ischemia of the uterus you are doing.
Yes.
So wherever it's possible, you do even that clips we apply, we take out.
Correct.
That is a temporary ligation because we want till that procedure gets over, the patient should not bleed.
Correct.
Yeah.
Prabha, I had one input about prevention of recurrent ectopic on laparoscopy
Yes,
because
ma'am.
I had the experience of stump ectopic once.
Yes,
And then
ma'am.
I kind of evaluated, I operated on the patient the second time. So when we perform, as you said, performing salpingectomy should never do a partial removal. You are very right. But there is a balance when you go to the cornual end. You should not overdo at the cornu.
Yes, ma'am.
We all know that you also said the same thing, that we should not injure the myometrium there because it is rather thin there. It is only 0.5 to 1 0.5 mm to 1 centimeter at the corner of the myometrium. So we should remain away. But what we can do is to cauterize the mesosalpinx up
Yes.
till the cornu so that the blood supply to that last part is not there. So that will help in preventing a recurrent ectopic. And I think once that area gets totally blanched, I think the endosalpinx will no longer be viable in that area. So we need to take more care rather than cut. We must cauterize in that area so that we save the uterine part also there and we prevent a recurrent ectopic. Yeah.
Correct,
Thank
ma'am.
you. Thank you
Yes,
so
ma'am.
much. Yeah. And your surgeries were just lovely. And as
Thank you, ma'am.
Rajeshri said, we are ready to wind up. Yeah. Your secretary can vote of thanks. Yeah.
Yes, yes, ma'am.
As we
Thank
have come to the end of this wonderful academic session, I would like to thank all the chairpersons, speakers, and for their valuable interactions. I now request Prabha Desai Madam, Chairperson, Kasoga Endoscopy Committee, to deliver the closing remarks and vote of thanks. Madam,
Yeah.
please take
See,
over.
actually, everybody is running late, so I will just cut short and I will thank everyone for your active participation. I express my sincere gratitude to our President, Madam, Dr. Rajeshri Palladi, and our beloved Secretary, Madam Dr. Shobha Gudi, Madam, and all the distinguished speakers, chairpersons, and Kasoga office bearers, delegates, and the organizing team for their valuable contribution to today's successful webinar. And actually, everybody's has interestingly taken active participation in discussion. I special thank Dr. Rajesh Bhakta sir. In spite of his busy schedule, he has agreed in in one sentence, he agreed for his the contribution. Then Kasoga Endoscopy Committee remains the committed to bringing high quality academic programs that enhance knowledge, refine surgical skills, and improve the patient's care. Thank you all for your support and encouragement, and have a wonderful evening. Thank you, and long live Kasoga. Thank you, ma'am.